Welcome to the His Health webinar series. We're so pleased today to be joined by our good friends at the Connecting Resources for Urban Sexual Health, or CRUSH program, out in Alameda County in California. Today's webinar is entitled From Implementation to Practice, Critical Considerations in Establishing a Sexual Health and HIV Prevention Clinic for Young MSM of Color, the CRUSH Experience. We are so very fortunate to be joined by the director of that program, Dr. Ifeoma Udoh. Dr. Udoh is the Director of Monitoring and Evaluation for Pangaea and the Research Director for Pangaea's Oakland NIH studies. Dr. Udoh has extensive experience in implementing international and domestic HIV/AIDS programming, monitoring, and evaluation activities in low-resource settings around the world, including the Caribbean, Asia, and the United States. She currently leads Pangaea's projects in the Dominican Republic, China, and Oakland, California. Ife's research interests include the design and use of rapid assessment and ethnographic methods to inform program development, with a particular emphasis on communities of color and those that are most at risk, such as male and female sex workers and people living with HIV. We want to thank Dr. Udoh for joining us, and I'm now going to pass the mic to her to lead this presentation. Take it away.
Great. Thanks for having me, and I'm really pleased to be able to share the experiences of the CRUSH project here based in Oakland, California. And this talk is primarily focused on what it takes to move from implementation to practice, and what are the things you need to think about in terms of establishing a sexual health clinic and HIV prevention services for young men who have sex with men who are of color. The CRUSH project has been in existence since 2012, so we've learned a lot about this very specific area of thinking about how to shift clinical focus and clinical programming to expand services for young men of color, young gay men of color, within the context of HIV prevention and HIV care and treatment. So I'm happy to be able to share these experiences with you. Next slide, please. Before I begin, I just wanted to acknowledge and give our consideration and our hearts and our thoughts and our minds to the situation in Orlando. It has affected the CRUSH project in a very personal way. One of our key staff people on the CRUSH project knows somebody who passed away in that horrific event this week. And our thoughts are with her, and our thoughts are with the families and the communities in Orlando, particularly as this is striking and horrible to men of color, men who have sex with men who are of color, and the horrible hate and bigotry that was showed there. So we just wanted to be able to acknowledge that before we started this conversation. Next slide. So a bit about the presentation outline. Today I'll go over the context and background, give you a little bit of information about where we are situated and where the CRUSH project lives, then go through the CRUSH overview and give you a sense of what CRUSH means, what it's about, what we do, walk you through the key implementation steps. I'll talk a lot about our community engagement process, which has been essential and is crucial for any program that's thinking about expanding services in this way to young gay men of color in a clinical setting. And then I'll give you our lessons learned and key considerations, things that you all should be thinking about in developing these sorts of programs in your own settings. Next slide. So just very quickly giving you some sense of where we are situated within the HIV/AIDS epidemic in Alameda County. Between 2010 and 2012, the majority of the new HIV/AIDS cases in Alameda County were among men who have sex with men. Nearly 70% of those cases were men who have sex with men. Alameda County is based in Northern California. We are the county across the bay from San Francisco County, and Oakland specifically, its largest city, is a city that is very urban and dense in population and boasts nearly 750 different languages and cultures and communities. So it's a very diverse area, diverse city. And the HIV epidemic here specifically is mostly impactful in the men who have sex with men category. Next slide, please. And more specifically, with regards to the CRUSH project, the epidemic here in Alameda County between the ages of 18 and 29 made up 81% of all new youth cases during that same time frame between 2010 and 2012. And in addition to sort of the context of what's happening with regards to healthcare and healthcare access, as everyone knows, the Affordable Care Act, and in particular here the framing of the Affordable Care Act in California, which is called Cover California, really pushed younger people and has been pushing younger people to become insured in the healthcare system, which is important and it's great, and it allows for an opportunity for young people, whether or not they're positive or negative, to begin to engage in their own healthcare. However, in Alameda County, we do not have a municipal or a public-supported clinic that provides STI treatment services. STI treatment and HIV treatment is mostly done in the public hospital setting. We have a huge public hospital, Highland Hospital. We have our private hospitals, Summit Hospital, where the CRUSH project sits. I'll talk a little bit about that, and Kaiser. But we don't have clinics. We don't have small operational clinics in the county. This is a county of 1.2 million people, and we don't actually have public health clinics. It's a point that I like to try to make with regards to what access does there really exist in terms of young people being able to get sexual health services. And so why a sexual health clinic for young MSM? Why is that necessary, and what would that model look like? Next slide, please. More context and history. As we all know, Truvada as PrEP became FDA approved in 2012. So moving from efficacy trials to demonstration and implementation has become the critical questions and considerations that many of us are looking at in terms of how to implement PrEP within specific communities, and what are the sort of programmatic considerations, retention considerations that we need to think about for specific communities. And here in California, the California HIV/AIDS Research Project, CHIRP, began to ask those sorts of critical questions by establishing the Epidemiologic Interventions Initiative in 2012 in response to that, in which they were looking for novel approaches to addressing the HIV prevention and care continuum, so from PrEP to TLC plus, or testing linkage to care plus, so working with HIV prevention, and what are the linkages between HIV prevention services and HIV positive services that we need to consider, and what do those look like. And CHIRP was really interested in wanting to find more information about how to make those linkages work. And so they funded 3 sites in the state of California, invested a lot of money, and CRUSH became one of those sites. And the goal of CRUSH, and really the goal of the EII initiative, was to integrate routine sexual health services for young men who have sex with men within the setting of an existing primary health care clinic. So really the big question was, could we establish within primary health care centers that were focused on HIV care and treatment, could we open the doors to those HIV care and treatment centers to HIV negative communities, and for us specifically young people, and begin to provide prevention services alongside care and treatment services. So establishing the model health care for sexual health was what the overall goal of CRUSH is. Next slide. So context again about where CRUSH sits and where it is established. CRUSH sits in a clinic called the East Bay AIDS Center, EBAC. It's the largest HIV care and treatment center in Alameda County. About 1,500 people access their care services there. And it is a center that provides primary care and wraparound services for positives and negatives as well. And in 1997, EBAC established what is now known as the Downtown Youth Clinic. So within the walls of EBAC, there's an operational clinic that services HIV-positive youth between the ages of 13 to 29. EBAC considers the Downtown Youth Clinic sort of a clinic without walls, in that it allows the opportunity for young people to access care services in the way that young people access care services. So there's flexible drop-in appointments. As we know, young people sometimes don't show up on time, or they sometimes miss their appointments because their lives are so busy. And so there's opportunity to sort of flexibly drop in as need be for your care and treatment appointments. Lots of communication for young people through text and text messages and email messages to get them to come in, and a lot of times even meeting them either at their homes or at other residences, other agencies to provide services to them. EVAC also has a dedicated youth team as a part of the Downtown Youth Clinic where they have their own provider, they have a social worker, medical social worker, and they have peer advocates that are attached to that program. So this idea that there's clinic without walls and that there's wraparound services available for young people to keep them in care. And as you can see, of the 220 plus positive, HIV positive folks that we have in care, over 80% of them are men who have sex with men, and 70% of them are virally suppressed. So being able to set up the DYC to support young people to be engaged in routine HIV care has been an incredibly meaningful and effective process for keeping young people engaged in care. Next slide, please. Next slide, please. So based on the experiences of the DYC, CRUSH has some very specific goals in place and aims that it's trying to accomplish. Could we actually use the experiences of the experiences and the examples of the DYC to establish a program which would enhance similar services for HIV negative folks? Could we use the experiences and the lessons learned from working with positives and keeping positives retained in care? Could we use those experiences and lessons learned to work on HIV prevention for young gay men of color? So with that, our specific aims were to test and link young men who have sex with men of color into sexual health services, to enhance and evaluate engagement retention strategies for young positive people who are living with HIV, and to engage and retain young HIV-negative men who have sex with men in sexual health services, including PrEP. And so for us, the idea of implementing PrEP within an existing HIV clinic was about enhancing routine sexual health services, establishing a place where young gay men could come through the doors and get routine HIV testing, routine sexual health testing, including STIs, syphilis, gonorrhea, chlamydia, and get checked and get tested in the very culturally appropriate ways and culturally sensitive ways that young gay men need to be addressed throughout their system of care. Next slide. So this slide just sort of shows a little bit more about our conceptual framework in terms of how we thought about CRUSH. So again, using the existing model, if you look over to, I suppose, the left side, so my left side, your right side of the screen, using the existing model of the DYC and working to enhance services for HIV positive young people, which included for us not just the linkage and retention work that was already taking place, but also establishing a peer mentoring program. Community engagement with new partners, so pulling in new people, new ideas, new partners in the community to help us think about how we could enhance our existing referrals and enhance our access to being able to provide information about sexual health care services to HIV negatives, and then actually providing those sexual health care services for HIV negatives, which include warm handoffs to a prevention case manager, repeat HIV and STI testing every 3 to 6 months or on an ad hoc basis as we learn throughout the implementation of CRUSH, PrEP, PEP, which is a really huge consideration that I'll talk about as a part of this project, risk reduction counseling, and youth-focused and youth-centered workshops. So all of those sort of services to support HIV positives and negatives within a system of care is what the CRUSH project aims to do. Next slide. And this slide just sort of reiterates some of the services that we provide to both the negatives and the positives. So, of course, with our negative cohort, those that are seeking PrEP, seeking PEP, or need PEP, we have a retention specialist who works to keep those folks engaged in care. We provide HIV testing, including a very highly specialized test called the nucleic acid test or the early test, which allows for acute HIV testing within 5 to 7 days of exposure of being exposed to a potential HIV infection. We are able to actually test and find that acute exposure. PrEP, of course, PEP, post-exposure prophylaxis, primary care referrals, benefits counseling, which has become huge, and I'll talk a little bit more about how important that's been to the project, and social support activities, as well as for the positives, very similar work that's done with the positives. So primary care services, peer advocacy, obviously access to antiretrovirals and support from a social worker, as well as peer mentoring and peer support and clinical supervision for the staff who are working with HIV positives, which is also a critical lesson learned for us. So really integrating these services at the clinic to support sexual health for both positive and negative gay men is what CRUSH is about. Next slide, please. To do this, we have a plethora of community and scientific partners. You can't implement can't take on a huge endeavor as this without ensuring that you have lots of community support, and you have lots of scientific support to help you understand if what we're doing is working, and if not, what do we need to shift, and if the messages that we are providing in the community are working, and if not, what do we need to shift. So having tons of community and scientific partners to implement these kinds of services has been really critical for us, and as you can see, we work with a lot of different organizations based in Alameda County and based in San Francisco, including UCSF, Gladstone, La Clinica de la Raza, HEPAC, Asian Health Services, RISE, which is a youth center that is focused on social justice issues here locally in Contra Costa County, which became incredibly important for us as we learned that young people didn't always want to be associated with the AIDS service organization. They wanted to have the opportunity to go to different places, and so being able to partner with a broad range of community and scientific partners is essential for this kind of endeavor. Next slide. So very quickly talking to you about who we actually are seeing and what our cohort looks like for the CRUSH project. We began implementation in February of 2014, and since then we've seen nearly 400 youth, about 280 HIV positive and about 100 HIV negative young people. Everyone is beneath the age of, or between the ages of 18 and 29. The majority of folks that we saw fit in the 21 to 24 age range and the 25 to 29 age range, as you can see. We focused, as I mentioned earlier, on men who have sex with men of color, and 70% of our cohort is exactly that, spread across Asian and Pacific Islander, African American, Hispanic and Latino, and those who identified as mixed race. It was completely important to us and necessary for us as we are implementing and worried very desperately about the state of HIV and AIDS among young men of color. And so we really focused highly on getting young men of color into these types of services and care. Next slide. We obviously focused mostly on young men of color, but we did also have young women, and we also had a small cohort of trans people, both trans men and trans women, who came through the doors of CRUSH seeking services, including PrEP and PEP, as well as seeking services for HIV positives. And the majority of the young people that we saw in terms of their sexual orientation did identify as either gay or bisexual. Next slide. So I'm going to move into this conversation about how we really engaged community and how we engaged partners to get these folks through the door in terms of what kind of services we provided and what the role of community is in actually supporting that service delivery structure. So working with community partners, establishing a robust community advisory board, developing outreach materials, developing websites, and really using your patients and your participants as your key resources. If you get the opportunity after this presentation, please take a look at our website, crush510.org. 510 is the area code for Alameda County and many of its cities. And the the banner name for the website came directly from feedback from our community advisory board, which I'll talk about in detail next. Next slide. So very quickly, in terms of getting people through the door, it takes a lot of sort of effort in a lot of different places. Getting people through the door to come into these kinds of services took not only working with our community-based organizations, working with other providers in the community, training our staff. So many people that we saw in the clinic were referred in because our staff, both the nurse practitioners and RNs, medical assistants, administrative staff could talk to people about what CRUSH is. And then, of course, our study participants. And so this slide really sort of depicts the broad range of ways to think about how to engage young people and who can become partners in that engagement, and to not think about it so narrowly in terms of it just being a community partner or a person. It could be anybody across these broad ranges of ways of thinking about how to engage young people in systems of care. Next slide. So really quickly, some lessons learned, some early lessons learned from integrating HIV negatives into an HIV clinic for HIV positives. I should say positives at the top, excuse that typo. So some of our early lessons learned, that at the beginning of the project, there was a high percentage of folks that came through the door at their baseline visit seeking PrEP but actually needed PEP. So really being able to work with your staff to understand what kinds of screening questions to ask, what sort of steps and triage steps need to be in place in order to get people into a PEP services, which for us at a clinic level, we consider an emergency. When somebody comes in with an exposure within 72 hours, we consider the need for PEP something that needs to happen ASAP. And so training the staff to understand what that process is about and how to get people into PEP. But we also learned very early on that while PrEP was building in popularity and people were seeking PrEP and wanting to come in and learn more information about it, once they came through the door and they were screened properly by either our retention coordinator and or our nurse practitioners, it turns out that they needed PEP. And so PEP and PrEP services need to go hand in hand. Many young people, particularly young HIV negatives, don't have insurance, but they also qualified for Medi-Cal and Covered California. And so, again, for us as a critical lesson learned, once they came through the door, we understood that these are folks that want to be able to seek services and are asking to access services like PrEP or PEP, but didn't have insurance and didn't have access to understanding how to sign up for insurance. And so we immediately engaged in the clinic with the clinic's benefits counselor, and we actually diverted some of her time to our project to help us sign young people up for the ACA and in particular the Covered California process. And so that became a critical lesson learned right off the bat. One big sort of huge lesson learned in terms of clinical and systems implementation for negatives is that the negative implementation the negative implementation of services within an HIV clinic required lots of support at the health information systems level. So again, if you remember, EBAC was a clinic that works primarily for HIV positives, and so the electronic medical record system, of course, is set up for folks who are HIV positive, who are signing in for ARV treatments, who are coming in to see their HIV care providers. And there was a whole system overhaul that we had to consider in terms of people that were coming in for HIV negative services that we needed to consider. So lots of sort of work behind the scenes with your health information systems is something that's crucial to think about in terms of integrating these services into existing clinics. Establishing warm handoffs for primary care services for HIV negatives was huge. HIV negatives coming through the door of EBAC were usually coming in only for PrEP or PEP or sexual health care services, but if something other than those issues around sexual health were coming up, like asthma or high blood pressure, we needed to have strong community stakeholders, and such as some of our partners, such as Asian Health Services, who I pointed out earlier, who could actually take those patients on for us to see them for other primary healthcare services. And lastly, a big sort of critical lesson learned early on was we needed to have a lot of community-level conversation with partners to talk about, well, what does sexual health mean? What are the actual outreach messages for young men who have sex with men who are seeking sexual health? Sexual health is a huge and broad topic, and historically, when we think about sexual health, I think we think about it specifically for women. Think about reproductive health care services. We think about the history of providing reproductive and sexual health care services for women. And obviously, with the HIV/AIDS epidemic in the last 30 years, we've pushed the envelope in terms of thinking about sexual health for other communities, particularly gay men, gay people. But it became a huge sort of, not issue, but consideration for us with our partners. We had to have lots of conversations with our partners to say, well, what does it mean to be sexually healthy? What does it mean to be sexually happy? What are we promoting in terms of sexual health for young gay men, and how do we actually talk about these things in our outreach messages? So generated lots of interesting feedback, which ultimately did things like shape our website and shape sort of the materials that we proposed, and shaped our discussion. We don't talk about HIV prevention and PrEP without the context of talking about that in sexual health care services. So those became really critical lessons learned right off the bat. Next slide. Administrative challenges in working within a big hospital system. EPIC, which is our new EHR at the time, electronic healthcare system at the time. I'd spoken about that a few minutes ago, and needing to sort of create some shifts in how things were oriented in EPIC, particularly around registering patients through the door, patients that were not positive. Developing a huge clinical flow is ever crucial and ever changing. So clinical flow systems for HIV positives being what they were, could we model the systems for HIV negatives and having them sort of come in and out of the care system? Which also meant a lot of cross-training of staff, making sure that everybody in the clinic, from nurses to RNs to medical assistants, knew about the HIV testing procedures, intake procedures, lab processing, referral processing, et cetera, which also led to this sort of need and necessity for strong interagency collaboration. So working very clearly and communicating with all aspects of the clinic, from the administrative staff who are checking people in to the nursing staff who are treating your STIs, and finding out from them very clearly what they need to do their work and how these new programs were impacting their work. So again, you know, the clinic was an HIV care site, and CRUSH allowed for this opening of doors for HIV negatives to come through the door, and particularly negatives who had not been previously tested for STIs. And so in the beginning of our project, we literally increased STI treatments threefold, and the nurses were sort of freaked out when they saw all of these STI treatments coming through the door. So really having to sort of explain what was going on in the community, explain this expansion of services and how that was going to impact their work, and being very thoughtful about that in terms of, you know, room utilization and managing clinic flow, particularly with young people and their schedules being as they are, not necessarily showing up on time. All of these things became really crucial for us as we expanded the operations of the clinic for negative people to come and access sexual health services. Next slide. So again, I'm going to go back into this conversation around community engagement, working with our partners, establishing a community advisory board. And I know Maura's on the phone with me. Are we sure? Does the link work? Can we actually play the link?
Hey, Faye, yeah, I just sent you an email. The link unfortunately won't work, but I did put it into PowerPoint so that the participants could take a listen on their own following the webinar. Got it.
Thank you. So one piece of information I wanted to share with you, and lots of different sort of pieces of information I wanted to share with you about community engagement, that you can actually have your community advisory boards be robust and be a part of the discussion around sexual health and lead those discussions for you, and really help your organizations, help your programs understand how best to talk about these things, not just from a community perspective, but even how to train providers on how to talk about sexual health for young gay men. And I'll talk more about how we really took advantage of and worked very closely with the strong community advisory board to do so. But if you get the opportunity after this conversation to listen to some of the links that are presented here, there's an interview here that was done by one of our really amazing CAB members on NPR's Youth Radio that really describes, I think, the essence of why it's important that we do this work with young gay men and young gay men of color, and how they feel about their own health care and what they think about what's important and meaningful to them. So please take the opportunity to have a listen to that. Next slide. So again, we had several community partners. Rise Youth Center, which was our non-AIDS organization-specific partner. They're a social justice organization based in the next county over, and really sort of helped us think through conversations of trauma and conversations of social justice and other ways to orient ourselves to reaching out to young people. HEPAC, or Casa Segura, which is our needle exchange program in Alameda County, has a very strong youth presence with young drug users, and was crucial to us in terms of thinking about how we engage that population. Asian Health Services, which is a primary care clinic in Alameda County, very closely located to EBAC, so we were able to set up a system of warm handoffs between CRUSH and Asian Health Services, and as well as other organizations such as La Clinica de la Raza as well. So those community collaborations are critical in terms of establishing these sorts of services at your clinic. It's clear that not one clinic can take on all the things that young people need and want. You have to be able to have access to other places and be able to warmly hand people off to other places in ways that don't make young people feel like they've been abandoned through the process. Next slide. So to talk more specifically about our Community Advisory Board, this is sort of the heart and soul of the CRUSH project. I'm going to focus on community representation, bidirectional educational opportunities of the CAB and how you support educational opportunities of your CAB members, and some of the activities that your CABs can participate in, such as developing your outreaching and messaging materials. Next slide. So our CAB meets actively 9 times a year. We have 12 months in the year, and we only skip 3 meetings a year. We take the summers off and the Christmas month off of December. So we are pretty active with our CAB. They see us, we see them. And our key activities with our CAB are focused on messaging and media and things of that nature, but expanding it out to just more thinking about passing out leaflets or handouts. They helped us develop our website. We have a couple of webisodes that are also on our website that would be really interesting for you to check out, where they actually wrote the scripts for those webisodes and acted them out. So really being able to create opportunities and creative opportunities for young people to engage in helping you get the message out is very critical. Investing in their development. So this idea of bidirectional education, community advisory boards are meant to advise projects on how to better do their work, how to better engage in community, how to better create bridges between what's happening with your program or your projects and what's happening at community-based settings and the folks that you're trying to engage. But also, they should be bidirectional in that you're learning from them, but they're learning from you. And so for us, what that meant was being able to use time in our routine meetings to have a speaker series, to have people come in to the CAB meetings and talk about PrEP, Robert Grant, who is the protocol chair for the IPREC study, was one of our first off speakers with the CAB, who came in and did a whole PrEP 101 with them so they can understand what it means and how to talk about it and learn for themselves the science behind it. We've had speakers come in and talk about the Affordable Care Act. We've had speakers come in and talk about the global HIV epidemic with men who have sex with men. And we also held a very sort of specific set of speaking engagements with trans communities and trans programs throughout the Bay Area, because that became a critical focus for the CAB and the project, was how do we further engage with the trans community. Well, we needed to educate ourselves and educate the CAB on that. And so really creating these bi-directional opportunities for your community advisory board to learn from you as you learn from them is incredibly crucial. See your CAB as your community ambassadors. We have our CAB members serve in very specific leadership roles in which there are titles that they themselves came up with. So our media liaison is someone who we always call on whenever there's a conversation with the newspaper or the radio. Our scientific liaison sits on the CAB, but also sits in the meetings with the principal investigators and the research director, myself, and the staff. So he's directly linked to the implementation of the work and can report that information back in the routine CAB meetings. That's a huge role and something that's definitely, I would advise other programs to consider, that you don't keep your CAB separate from what's going on with the work. We had an education director of the CAB who was responsible for helping us pull together some of those bi-directional opportunities. So really giving your CAB the sense that this is their project, they get to own it, and they get to lead it, and they get to define what that leadership means is super important. And giving them the opportunity to use that leadership in various venues, whether or not it's within media coverage or community outreach or participating in community forums around your local neighborhoods, your local areas. Next slide. So again, we had this process for our CAB of really helping us support our outreach messaging in this very creative way. And through one of our community partners, Rise, which one of the things that they do very well is social media and digital messaging, we were able to develop a set of mini webisodes, these 2-minute videos, educational videos, young people focused, one specifically on STI treatment and one specifically on PrEP access. And if you have the opportunity, please take a look at them. I think you would find them worth your while, and just also to give you an idea of how you can fully engage young people in your environment to help you develop messaging and giving them sort of a creative outlet for that. The CAB wrote both of the scripts for our webisodes and acted out did the voiceovers for both of the webisodes as well. So please check those out. Next slide. Our CAB, again, also focuses on developing these types of culturally appropriate materials, and they're heavily vetted. It's a funny story about our website in particular. Our first attempt at trying to establish a website went horrendously wrong. And we had not the right pictures up, and we had not the right messaging up. We had not the right ways to think about how to talk to young people, and didn't even have the capability so that the website could be looked at on phones or on tablets, which is obviously what young people are doing to communicate nowadays. So when we showed our first attempt to the CAB, but before the end of the meeting, we had to take the website down and start from scratch. And that was sort of a critical lesson learned for us right off the bat in terms of our implementation. So again, being able to bring them fully into the process from beginning to end takes a lot of time and a lot of energy, but at the end of the day, you end up having really beautiful messages and materials that are reflective of the communities that they know will see those and will be able to access those. Next slide. This is the screenshot from our website. So just again, just in terms of sort of really capturing the heart and soul of their feedback and how they wanted us to really have the website be reflective of young men who are reflective and not sort of seen in the traditional ways that you see over-sexualized and hypersexualized gay men in flyers or websites. They really wanted us to have something be unique to their perspective and fun and beautiful, and even the whole slogan, take charge of your sexual health and have fun, that you can be healthy and you can still have fun and you can still participate in your lifestyles and in the ways that make you happy was something incredibly important to them in terms of the messaging that we got across in terms of our website. So again, if you have the opportunity, please check it out. Next slide. So some critical lessons learned in engaging community-based or engaging community advisory boards, how to implement them and how to integrate them into a youth-based clinical setting. Takes a lot of management, takes a lot of work. As I mentioned, the CAB meets 9 times a year. We have an outreach and linkage coordinator attached to the project whose main role, one of his main roles, is not just communicating with partners, but also working with the CAB. He is the core person that the CAB centers around, and having a person who organizes the CAB and gets information out and gets responses back. It's a lot of work, takes a lot of time and effort, but it's totally worth it. We are talking about young people, and so establishing routine ways to communicate them, routine meetings. Our meetings take place on the 3rd Tuesday of every month, and so it's sort of hard to forget the 3rd Tuesday of every month. In the beginning, it's hard to get the meeting going, but once you've been doing it for a year, everybody knows the meeting takes place on the third Tuesday of every month, and because of that, we have a really robust turnout at our CAB meetings. Remembering that CAB recidivism is normal, remembering that young people move around a lot and they have lots of things going on in their lives that prevent them from being as active as they want to be, and creating ways to give them opportunities to be more active. And I'll give you a really quick example. We have a CAB member who is incredibly important to the CAB and has been on the CAB for a long time. She is currently our only trans person. It's taken a lot of time and effort to recruit trans people on and off the CAB. And along the way, we've had recidivism of trans participation. But this person is highly motivated to be with us and highly contributory when we are with her and responds to emails and texts. But she has a very hard time coming to the meetings because the meeting times fall during a time where she has to be at work. So we've actually, at certain points, shifted our meeting site to go to her job. She works, fortunately, at a place where there's conference room facilities and conference room space. So we've actually shifted sometimes our meeting sites to actually go host our meetings on site at her job so that she can actually come and join the meetings. So just being really thoughtful and being creative about how to keep your key members, your critical members engaged, and being open to those kinds of ways to move things. And the rest of your CAB members will follow. They know and appreciate how important it is to keep this person engaged, and so they come to those meetings without issue. Consider your CAB instrumental, and not just in terms of community messaging, but also as your referral partner. Many of our CAB members are also participants of your program, and they are also very well connected in their social networks. And so people will come through the door if they trust the message that's coming from their friends and family. And acknowledge their hard work. I think while there are lots of opportunities for bi-directional education and training, you're asking a lot of young people to come to you and share their thoughts and experiences in a safe place, in a safe setting. So acknowledge the work that they are putting into it. And again, moving into this project's 4th year, we have about half of our CAB members who are original CAB members who have been with us since the beginning of the project, since 2012, which is pretty darn incredible. And they've worked that hard alongside with us in terms of implementing the work. So acknowledge their hard work. Next slide. One way that we did that this year is that our CAB received a Global Health Leadership Award, which was given to them by the Pangaea Global AIDS Foundation, but also provided a commendation from Congresswoman Barbara Lee. So we're very proud of them, and they were very proud, as you can see in this photo as well. So again, acknowledging their hard work and acknowledging that they have a stake in the community as well, and they're committed. Next slide. So to wrap up, some discussion points and implications for youth-based clinical programming that I'd like to share with you based on our experiences with CRUSH. Next slide. So integrating sexual health services into a clinical care HIV setting, administrative challenges, working within a hospital system, new registration processes. Some of this you've already heard. Being very clear about working across the board with all aspects of your administration, whether or not they be the front desk staff or whether or not they be the medical assistants, whether or not they be the social workers or whether or not they be the cleaning staff. The cleaning staff had to be very aware that there were materials that were going to be left and scattered in some places by young people, and helping us sort of maintain our stock, so to speak, in terms of our outreach materials instead of throwing things away. So talking to everybody is super important, that interagency collaboration. Next slide. Providing options for youth to access services, specifically regarding HIV and specifically regarding STIs, means being very open and very non-judgmental, specifically around gay men, gay male sex, and what that means. And so some of the things that we learned to do and some of the things that young people told us that they needed to learn to do, that we needed to learn to do, were actually clinic-based recommendations. So, for example, some of our young people are hesitant about getting rectal swabs or hesitant about getting needle pricks and being super easy and careful about that. So we actually give the option for young people who are coming in for STI treatment to do their own rectal swabs and to hand us back, obviously, the swabs so that they can go get tested, so they don't feel as if though that they're being invaded or judged by their provider. So really sort of thinking at a clinical level the ways that young people might feel more comfortable so that they know that you're not being judgmental of them is important. Rethinking some of the clinical retention for young people, and again, I think I mentioned this earlier, but this idea of missed visits versus late visits for young people, those sorts of ideas almost need to go out of the door, because youth come in when they want to come in. So you could schedule an appointment at 2:30, and some of those youth, probably 50 to 60% of them, will come at 2:30. The other 40 to 50% of them are going to come somewhere between 2:30 and 6. And so you have to be flexible in that your clinic operations have to be able to accommodate that youth are going to come when they want to come. And it could be they come between 2:30 and 6 the following day, but you still have to see them because you don't want to lose them in your system of care. You still want them to come in. So that's incredibly important for clinics to think about, and it's a huge shift as well. Along those same lines, long clinic visits are a deterrent to young people, as we know. You lose people when they have to wait a long time in general, and you're definitely going to use them if they're young people. So one of the ways that we try to mitigate that is that we have a youth-specific waiting room that's got a television in it, it's got Netflix on it, there's charging stations in there, they can hang out, they can do their thing if the waits get a little bit long. So giving them space within the walls of the clinic to keep them engaged. And then again, acknowledging sort of the clinical systems and capacities and understanding that when you expand these sorts of services in existing settings, that that everything expands. The workload of the nurses expands. The workload of other staff expand. And so really being able to sort of work closely with those different teams and appreciating that everyone is doing their best to try to get those services routinized for young people. Next slide. Some considerations for sustainability, and particularly for programs that are implementing PrEP. CRUSH was and is a research study, a demonstration project looking at how to best implement PrEP and prevention services within an existing HIV clinic for positives. But also what that meant is that we had to really think through what happens beyond CRUSH. What does CRUSH turn into beyond the 4 years of funding, and how do we sort of maintain the services of CRUSH in this place in Alameda County where there isn't an STI clinic, and we want these services to continue for this population. We don't want to lose our cohort to not having access to routine care. So what does that mean? It means implementing or having a benefits counselor who can help people get signed up for insurance, particularly young people. It means integrating HIV prevention within an HIV clinic and training all providers to being able to do that. So HIV providers who are skilled in working with HIV positive people need to know how to be skilled in working with HIV negative people as well, particularly young people coming in for STI treatment. So being non-judgmental and being able to sort of speak to the needs of young people who are positives and negatives. It's crucial across all provider training needs. The need to address frequent PEP. So again, young people and who are accessing PrEP, as I mentioned earlier, a lot of sort of interplay between the PrEP to PEP continuum, and being able to sort of have a PEP protocol in place that could be accessed routinely by the providers and by the young people as well. Some challenges in implementing a use-based clinic is that everybody knows each other, so really being thoughtful about confidentiality, sharing of information, where young people enter and how they enter into the clinic sometimes could mean that they know people that are coming through the door, and how do you sort of manage those boundaries. And again, a lot of training around professional development, boundary setting, and leadership for your staff, particularly young people who are leading your work in terms of working with other young people, keeping opportunities for them to professionally develop and increase their skill set as well is very important. Next slide. Addressing health literacy for young people in a very quick way. So one of our youth advocates called this the quick touch approach. So being able to spit out quick and dirty bullets about HIV or STI is super important. Young people are not going to look at a big old pamphlet with lots of information in it. More than likely it's going to either end up crumpled on the floor in your clinic or crumpled on the floor on the train somewhere. So being able to have quick at your fingertips, really quick bits of information for them so that they can walk out of there with something is important. That's also sort of connected to this idea of routine and recurrent STIs. So more information needed for young people that's quick and digestible so that they can reduce the recurrence of STIs as well is important. Having your CAB be a part of community advisory boards and community education. So again, having your CAB help you develop these sorts of tools is one way to incorporate their ability to influence your project. Having young people means being very non-judgmental in terms of your work capacity within the clinical setting, which can be hard. It's a hard transition, I think, for clinical settings to be non-judgmental towards young people whose lives are sort of up in the air and move at sort of their own pace. And so how do you sort of work that into the ways that you think about doing work in a clinical setting? And again, maintaining this process of warm handoffs and ongoing linkage to ensure that young people get supported through systems of care, whether or not it be their insurance coverage or whether or not it be primary care. like to take a moment to acknowledge not only our funders, but our entire staff, our entire team, our research team over at UCSF under the direction of Janet Myers, obviously our Community Advisory Board, which has been incredibly crucial, as you've heard, through this process to establish this clinic, our many scientific partners at various organizations that have helped support some of the scientific learning that we are learning from this project as well. And of course our funders, Gilead and CHIRP. Thank you.
Ife, thank you so much for that presentation and for delineating sort of the importance of meaningfully involving patient populations and patient communities really into the work that you do. Really amazing work. And we have quite a few questions regarding the CAB and the work that you're doing with the CAB. We have one participant who says your CAB is amazing. What was your first step in developing the CAB, particularly around recruitment? So what was the recruitment process for selecting participants?
Yeah, it's a great question. So when we started the project back in 2012, let me answer that in twofold, and that the way that we started the project in recruiting is very different from how we sort of continued recruiting when we dealt with issues of recidivism, which I'll talk about that. But when we started the project in 2012, as you recall, I mentioned the Downtown Youth Clinic was already established at EBAC, and many of the staff that were working for the Downtown Youth Clinic knew those 220 youth inside and out, and they also knew a lot of their partners inside and out. And so we were able to tap into staff's recommendations first of who they thought would be solid people who would be willing and open and wanting to talk about either their HIV status or wanting to have their partners come talk about their own sort of partnerships. Their HIV negative partners can be community centered. We asked our community partners, and so we went and talked to Asian Health Services and HEPAC and RISE and asked them for recommendations as well. And one of the sort of recommendations that came out of that process, to be honest, is that our community partners are also members of the CAB. So the outreach staff that are associated to CRUSH through our community partners also are CAB members. And so the idea is that the outreach teams and the community partners have this sort of dialogue between the CAB members who are either patients or who were recommended to us by those community partners as well. So we didn't see them as separate entities, the community agencies and the CAB. We saw that as sort of the CAB as one place for everybody to dialogue about how to implement CRUSH services. And then as the CAB rolled along through the project, and as I mentioned, CAB recidivism is normal and it's expected. But a lot of times, if you ask a CAB member why they're leaving, it's because it's some circumstance in their life. You know, work has shifted, housing has shifted, something has changed in their experience that they're having a hard time managing. It's not that they don't want to be there, it's that they can't. But what that also means is that you can give them an opportunity to actually help shape the continuation of the CAB in their stead. And so for our process for dealing with recidivism is the CAB members that are leaving, we would ask them, well, who would you recommend? Who can you tell us that if you can't be there, if you can't be there, who else do you say that we should have as a part of this CAB? And we would have them contact that person and put them in touch with us. So a lot of our newer CAB members are actually recommendations from CAB members who have left the process, and so that sort of keeps the tie to that person, that CAB member, and keeps us rooted in the perspective of having a diverse CAB as well.
That's helpful. Another participant asked if you have any specific examples for how the CAB informs the delivery of health services.
Yeah.
Specifically how they inform like culturally competent delivery.
Yeah, really good question. So before the actual kickoff of the project, so as I mentioned, CRUSH started, we were funded in 2013, didn't actually see our first participant until early 2014. Our earliest intervention, quite frankly, has been our CAB. So the CAB got started right off the bat. We started the CAB in maybe May or June of 2013, so not too long after we got the grant. And one of the things that we did with the CAB is they went on a tour of the clinic. We walked them through the clinic flow. They met the providers. They saw what the clinic looked like. They told us where the clinic looked ugly. They told us where to put posters. They told us, how to make it more user-friendly. They gave us lots of feedback in that very specific way in terms of clinical operations. And then, as I mentioned earlier, some of our CAB members are also themselves participants or patients of the clinic. And so once you build a rapport with them, they will tell you very clearly what providers they like, what providers they don't like, what providers said what to them in the exam room, what feedback they wanted to be able to provide to somebody. One, I think it's about allowing them the space to understand that their feedback is incredibly important. Two, it's about not creating that invisible barrier between the CAB and the project, and so our providers have been invited to CAB meetings. Our principal investigator, our clinical director, they participate in the CAB meetings as well, and we have a scientific liaison who participates in the research settings and the research meetings with the doctors and the nurse practitioners. And so there's always a way that the CAB is in communication with the leadership of the project. And I think that has been crucial in terms of being able to keep the project really rooted and grounded in the perspective of young people who are accessing their services. We don't separate their communication from the actual work.
Another question, was the CAB involved in the selection of the community partners, or were the community partners already selected before the CAB came together?
Really good question. The CAB was heavily influential in telling us what they thought community partners should have. And so as you remember me mentioning one, and this was part of the formative work of CRUSH before we actually started implementing the project. So about a year before CRUSH landed, we did a lot of formative work in terms of focus groups and key informant interviews to sort of understand like what community partnerships should look like, what the clinic should look like, all these sorts of things that you think about before you actually launch a project. We spent some time doing that. And the one big piece of the one big piece that came out of that was the piece that I had mentioned before about having a non-ASO specific community partner be a part of the project. The CAB was very clear that that they didn't always want to feel like the only partnerships in this sort of setting were all HIV or AIDS specific. Like where are the other organizations that are doing work, and how do we engage them in these conversations around sexual health? And so that's how we actually ended up reaching out to RISE, which is a youth center based out in Richmond, who's heavily focused on social justice issues and trauma-engaged informed care for young people. That's what they do, and they're not an HIV organization. They don't do HIV work. They don't do HIV testing. So yes, the CAB was influential in that, and our young people who are accessing services were influential in those kinds of decisions.
Helpful. Lots more questions, but I'm just going to ask one more, and it's something that we've talked a lot about. Ife, you've always been very adamant about describing the work that you do at the CRUSH Project and the CRUSH Project as a sexual health services clinic, and not necessarily a PrEP clinic or an ARV clinic. There are some participants that are very much in agreement with you, but are also acknowledging the challenge of being very clear that this is expanding out to sort of more holistic health. When most of the funding is around HIV prevention, and how that can be sort of stigmatizing for patients, and I think folks like yourself who are trying to get folks to think more about the whole person. And so I think that the question is really like, what has your experience been with trying to negotiate the two, particularly when it comes to sustainability moving forward, where you get your funding and how to make that case to a funder?
It's a really good question, and yes, I highly acknowledge that it's a contentious discussion to have within the funding community and within your own clinical or programmatic communities. Perspective, which I think is maybe solely mine, but could be others, is one, I do feel that the conversation around PrEP, the development of PrEP, and the conversations that are as a result of having this HIV prevention tool have really shifted the HIV conversation. It's you know, for the last several years, HIV providers, researchers like myself, we've been so highly focused on treatment as prevention, and necessarily treatment as prevention, ARV treatment, getting people who are HIV positive into a care system, working to create sustainability in that system, which is necessary. And those, you know, if you look at the cascade for the United States, the drop-off between people who know their status and who are actually engaged in care is huge. And so there's obviously a lot of work that needs to be done still in that framework. But I also think that PrEP has pushed a dialogue in HIV that has long been dormant for several years, which is the prevention dialogue. And the prevention dialogue being what it is and being PrEP what it is has pushed a dialogue in terms of the idea of biomedical interventions and the idea of community working to enhance biomedical interventions. These are new conversations that were either dormant or were not being had over the last 10 years. And the PrEP has really pushed that envelope. And so HIV providers are now needing to talk to benefits coordinators and benefits counselors because there's systems that are changing around access to health care and medications and what that looks like. And community-based organizations need to be in contact with doctors and nurses because community-based organizations have been the forefront of where people access routine services, but now we're trying to get routine services into care systems, and how do you integrate all that? And so how that sort of ties back in, I think, to the funding stream and to this conversation about sexual health is that while funding streams are, yes, very siloed and have been very siloed for several years, I think you're starting to see organizations like the one that funded CRESH, CHIRP, start to be able to try to answer these types of questions. How do you think about integration? We're starting to see the CDC move in a direction of thinking through how do you think about integrating prevention services, reintegrating prevention services back into care and treatment services. These are all questions that people are starting to re-ask again because of these new biomedical interventions. And I think it is and will continue to change opportunities in terms of funding. And therefore, we have an opportunity as programs to influence what that conversation is. And so again, from the perspective of PrESH, we were clear that PrEP and PEP were not things that were done in a vacuum. They were things that were done within the context of sexual health for men. And so that's how we thought about it. That's how we put the grant together. And I think there are starting to be some openings around those kinds of conversations. So I would just encourage people to not be discouraged and to keep pushing the envelope, because I think while these biomedical interventions may scare some people, they've also allowed opportunity for lessons learned across the board from funders to researchers to community and vice versa.
I think so, and I think the proof is in the pudding, too, in terms of utilization of services. When you contextualize it in that way, not everyone is sort of going to, and some might actually shy away from programs that, feel very much like there's an HIV scandal. So to me, what you're talking about isn't even contemporary thinking. It's really you're moving forward as if it's just common sense.
That's right.
So we'll collect additional questions. We're running out of time. Dr. Udoh, I want to definitely thank you so much for your time and for being such a great partner to his health. And also want to say personally, I think in light of what has happened in Orlando, that the work that you're doing is even that much more valuable in terms of offering a safe space where folks can get competent and affirming care that is affirming of their life experiences. But also that I think a lot of what you're doing is a part of contributing to society's debunking bigotry and homophobia. And those are the things that maybe cannot necessarily be measured, but it's about sort of changing minds and how we treat one another. So I just want to thank you again so much for your work. And we want to thank everyone for joining us. Our next webinar will be June 24th. His Health 2, will be exploring the sexual health needs for trans men of color who also sleep with other men. Ife, we don't thank you again, and enjoy the rest of your day. Take care.